Erica is a clinical professor in the School of Nursing at UCSF, and she's the director of the Family Nurse Practitioner Program. And through her collaborative work with community-based organizations on projects at local, state, and national level, she provides training throughout the country on areas of sexual and reproductive health, healthy sexuality for people with special health care needs, adult and adolescent relationship abuse and reproductive coercion, consent, confidentiality, and care of LGBTQ youth. So Erica, please do come up here and enlighten us.
Thank you so much. Well, thank you. That was a very warm welcome. I'm really delighted to have an opportunity to speak with you all today. This is an issue, I'm an adolescent and young adult healthcare provider, so this is an issue that is quite salient to all the care that I'm engaged in providing. But I'm also the mother of a about to turn 20 tomorrow, young woman with cerebral palsy. So I have a real personal interest in these issues as well. So I'm going to be talking with you today about healthy sexuality and adults, including young adults with disabilities. And I have no disclosures. And I realize you'll see if you look at the slides, there are slides missing because I'm one of those just-in-time kind of people. So I realized just this morning, I was like, oh, I didn't even really define what I'm talking about with sexuality. So there are a few extra slides here you'll see up here that aren't in your book. So I'm not going to read this definition to you. I'm going to give you a chance to skim over it, but I want you to look at the broadness of it. And I want you to notice that it includes not just the things that we think about in terms of sex and sexual and gender identity and roles, sexual orientation, but intimacy and pleasure. And these are things that we often forget about the needs for in our family members and in our patients or clients with disabilities. The other thing that I want you to really notice is that sexuality is not an act. Sexuality is not an action. Sexuality can be totally internal. It can be an orientation, a way of looking at the world, a way of experiencing sensations. So this isn't all about having sex. So sexuality is not genitality, but often we reduce it to genitality when we talk about it. And then we talk about, what is sexual health? And again, I want you to notice these are the WHO definitions, and I want you to really notice that what is required for sexual health. So a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. And these are issues that are present for everyone and are particularly salient for people with disabilities. So when we think about growth and development, we often think about it, certainly from the pediatric perspective, it's kind of you're done with adolescence or maybe young adulthood if you are aware of brain development and the issues of brain maturity maybe not being complete until the late 20s or even early 30s. But we think of development as kind of over. So development isn't over for anybody after adolescence, and it certainly isn't over for people with developmental disabilities. So physical development is generally complete. What is, and what's done's done, unless someone is going to make some efforts to make changes through the use of hormones in what their current physical development is. But in terms of the rest of development, brain development, emotional development, psychosexual, cognitive, social, ethical, spiritual. We talk about in my family that you don't know if you've hit the wall until you've been there for a while. So what's the end point? Do people with disabilities, do people with intellectual disabilities in particular, but people with disabilities in general who may be more socially isolated, have fewer social experiences, what happens with their social and emotional development? And I would posit that you don't know you've hit the wall till you've been there for a while. Because when we talk about delays, what delays mean is that you get there later and it takes longer, right? So I want to encourage you to always meet with your clients as people who have the potential, if they have the desire, to learn and change and develop regardless of their age. And then, is there typical development for people with disabilities? Well, first of all, people with disabilities is this ginormous conglomeration of variety of differences from typical or neurotypical or normative development. And so it's very important that you, like with anybody, that you really individualize your care. And yet be aware that there are a series of developmental tasks that are delayed for most young adults with disabilities. These are developmental tasks we often think of in the context of adolescence and young adulthood that are pushed into young adulthood and even middle adulthood in terms of individuating, separating from family if that happens, locus of control shifting. So there are a lot of things that happen developmentally in adulthood for people with disabilities, depending on their level of function and the disability that they have. There is a wide variety of cognitive and emotional growth, and this is more marked with certain disabilities than with others. And just always remember that maturation, as with children and adolescents and young adults, is not just this kind of nice, smooth, forward-moving process. It's often 2 steps forward, 1 step back. Sometimes it's 1 step forward and 2 steps back, but that eventually you see forward progression. So there are lots of myths about people with disabilities and sexuality, and these are some of the common myths: that people with disabilities are asexual, that sexuality isn't part of their life or one of their needs, or that they're hypersexual, or that they're solely heterosexual. Lots of assumptions about sexual behavior, and that sexual behavior for people with disabilities is inappropriate behavior. The assumption around capacity and consent, that people with disabilities do not have the ability to consent or are incapable of consent. That people with disabilities only partner with others with disabilities. Now, that's very unique to the individual. There actually was pretty recent research published on people on the autism spectrum who the majority of them said they preferred and felt more comfortable in relationships with other people on the autism spectrum, but, or with autism spectrum disorder, but this is unique to that study, and we don't know how generalizable it is. The issue of privacy. We are so ready to invade the privacy of people with disabilities, from asking them whether they're verbal or not, whether we may touch them, whether we can help them remove some clothing, whether we can look under a piece of clothing or touch under a piece of clothing, to not thinking that they should be able to close their door at home and not have anybody come bursting in. And then the assumption that people with disabilities can't or should not be parents. So what are the facts? So here's some of the facts. I have to say, this is, there's a lot of great websites for people with disabilities, mostly from Australia and Canada, not so much from the US. This House with No Steps has some really beautiful material, and there's a blog for people with disabilities. There's a lot of great material on it. So this is from their facts. And a few things that I threw in. So people with disabilities can be sexual, can have sex, can enjoy sex. They don't have to just have sex with one another. They are very diverse sexually, and we'll talk more about that. Again, newer data about people on the autism spectrum show that there's greater diversity than with neurotypical populations, and these are pretty large studies now that show much more sexual and gender diversity than among the neurotypical population. And with the right support, people with disabilities are capable of having healthy sexual relationships. And all people, every one of us, every one of our clients, need the opportunity to learn and understand about sex and relationships. And that means that the teaching has to be targeted in an appropriate way. And you can't assume that whatever's happening at school, which may be nothing for youth in special education classes, or may be totally inappropriate for youth who have different learning styles and needs, don't count on it happening at school. So one of the big impacts for people with disabilities is social isolation. Because really we learn about relationships from our context. We learn about relationships from our families, from our peers, from our social interactions, from the media. And social isolation and lack of typical peer experiences really limits social learning and is a pretty typical experience for a young person with disabilities. So structuring and supporting typical adult social experiences can really support social learning for people with disabilities. Many people need the basics. Again, you can't assume that the family has had the level of comfort or preparation to do this education, and definitely don't assume that it's being done in the school context in a way that your clients, patients, or family members can learn or relate to. So there's just some basics around hygiene and self-care. How do you take care of your own body? They need a lot of help understanding social relationships and friends, particularly, I said including in the virtual world, but I would say particularly in the virtual world, because this has been a great opening for, particularly for young people with disabilities who may be pretty isolated, that they can relate to others via the internet, that they can read blogs, that they can blog, that they can go on chat sites, etc. The risk is really when that virtual relationship transforms into an actual relationship, and that's a very risky transition. And so they need education and preparation about that. People with disabilities have higher rates of exploitation and abuse, and they need appropriate safety and exploitation prevention education. They need help understanding what's a healthy relationship. Often what we say in general adolescent development is that early adolescent friend relationships very much set the tone and predict romantic relationships in later adolescence. Children with disabilities often do not have close friendships. They often do not have wide social relationships. And so what prepares them for romantic relationships? What informs them about what romantic relationships should look like, or what they might even want in a relationship? So they need education about healthy relationships, and they also need help identifying what's unhealthy, what's exploitative, what's abusive, what's unsafe. And it's not just good touch, bad touch. I mean, good touch, bad touch is a fine place to start with young children, but it's not where you should end, and certainly is not the most appropriate messaging for adults who are interested in intimate relationships. And then they need information and education around sexual health and risk reduction, like anybody else. Now, when we talk about people with disabilities, again, I said we have this huge group we're talking about. So what are the issues here in terms of individuals with intellectual disabilities? And these are materials that are from the Sexuality and ASD, which is a governmental website in Canada. Again, excellent resource. So those of you who work with people with intellectual disabilities, or even just learning differences, know that repetition is important. It doesn't mean saying the same thing over and over again, but it means repeating the message in different ways, in different contexts, with different examples. And then always checking back for understanding, because if we think that our typically developing patients don't get it, you can imagine what our atypically developing patients might understand from what we thought we had communicated to them. So that teach back is really important. You need to stay concrete with your examples. This takes practice. It's different than working with typically developing individuals. But many adults with intellectual disabilities may not understand abstract concepts. They may not have developed abstract thinking. So the examples you use need to be concrete, tangible, specific, individualized, personal, and the use of social stories is a great tool for many people with disabilities. Again, something that we tend to leave behind when they leave childhood and adolescence behind, but can be very useful for adults as well. So this is an example of concrete examples of, what are your private parts and the concepts of private and public. But for adults, this is even more helpful. When, everybody has a camera in their pocket now, including our clients. The smartphones are very ubiquitous. Having pictures of private and public that relate to their environment. So if they're in a group living situation, that's different from being in a family home. What's private and public in a group living situation? What's private and public in the community? Do they have their own room, or do they share a room? Is their room private? Does the bathroom door lock? Is the bathroom? So really trying to work with them and their caregivers to develop social stories that really speak to their reality. So when we use the picture of the yellow bus and we say, this is public, if they take paratransit, it is not a yellow bus, right? Can they take that yellow bus and translate it to the paratransit, which is not private? Even if you're alone in the back, people in cars think it's private. Just sit in bridge traffic and that people in cars think it's private, but it's not private. So if typically developing adults sitting in traffic don't get it, you can imagine, if you're sitting in the back of paratransit, it might feel private, but it's not. And if you engage in any kind of self-pleasuring in the back of paratransit, it's going to be problematic for you. You're going to be kicked off of paratransit. You're going to be kicked out of a program. So these concepts need to be very individualized and specific. And I'm a great fan of social stories, but I have really become disenchanted with generic ones. And I think we really have the ability to make them specific, and we should. So you need to go slow, and this can be hard because we as providers have a lot of time pressures. We bargain for additional time for our patients with disabilities. We get half as much time as we think we need anyway. It's often a big deal for them to come in multiple times, especially if there's a mobility disability, but even with some behavioral issues where maybe the building is frightening to them or the environment, the smells, whatever, are uncomfortable for your patient. So you want to get everything done at once, but if you just blast them with information, you are not really communicating and they're not going to get the messages. So you really do need to go slow and take it in bite-sized chunks. Start with the basics. Do not assume they know their body parts, the function of their body parts, how to care for their body parts, and move on from there. And appreciate that your clients are sexual beings, and this can be expressed in many ways. Doesn't mean that they're engaging in sexual interactions with others, but they might. And that we know that just talking about sex doesn't encourage them to try it. It just helps them be better informed when and if the moment arises. So I don't want to be negative focused, and I think that the issue of no is really important. So clients need to understand that they have the right to refuse. We program them, we condition them to be highly compliant, right? There are strangers touching them, moving their bodies, doing things to them all the time. So understanding that they have the right to refuse and understanding how this fits into their context and where their rights might be impaired is important for them. Again, using social stories and social situations to understand when they might be in situations where both volitional, romantic, or sexual encounters might be possible, but also where abuse might be possible. The concept of expressing consent. And these are some, there are a few programs that have been developed for people with intellectual disabilities, and there's a new program for people with autism that has been, it's not in the US yet that I'm aware of, that is sexuality education that's oriented towards school-based sexuality education for people with intellectual disabilities and people with autism, two different programs that are very much tailored to the people with these conditions. But, what does consent mean? And really getting down to the nitty-gritty of what consent means. What do you do, how do you know when somebody wants you to kiss them? How do you let someone know that you want them to kiss you? Why is consent important? Why is consent on the part of both people important? Why is it important to verbalize consent if it's an individual who can verbalize? What is respect and what is privacy? And again, these are these very baseline issues that we really need to invest in educating and sharing information about. Privacy, certainly the public and private, and that sex is private, self-sexuality is private, sexual interactions with other people is private, and where is your privacy in your world? And how do you show that you respect someone? Why is respect important? For people with autism spectrum disorder, sexuality can be impacted by a number of different things. Certainly there are behavioral and information processing characteristics. They may have specific sensory interests or aversions. They may be hyper or hyposensitive towards touching. They may have preoccupations and compulsions or specific rituals. And so really understanding your client, their needs, their interests, their aversions, and then again, working with them in their reality, in their context. Not something that really lends itself to primary care, I have to say. This is, it's time intensive. It takes really time getting to know your client. They need to feel comfortable talking about these issues. So often these kinds of issues are better addressed in an environment where they have more time, where they have time to develop a relationship, where it's recurrent visits, so maybe in a therapy environment, sometimes in a case management environment, but often not in a primary care environment. With social and communicative impairments, this has a huge impact on social relationships and friendships. So right there you have this decrease in social learning and context. Anything that impacts on the development of friendships impacts on the development of romantic relationships as well. They have less opportunity to learn about sexuality from their peers. It influences one's judgment to apply sexuality in a socially acceptable way or in interpreting the sexual intentions of others. So how do you read your environment and how do you read the messages of others? And it can result in literal or incorrect interpretations of information related to sexuality. So often we try to make, particularly for individuals with intellectual disabilities who may have social or communicative impairments, we try to make it really basic. It can get so basic that it's not meaningful. And that it really doesn't give them the tools or the information they need around sexuality. So, these issues around sexual codes and interpreting others' intentions can be an important issue as well. And then this is a study that was done very recently on experiences of sex education and sexual awareness in young adults with ASD. And their conclusions were that young adults with ASD really did have specific needs and requirements that were separate and different from those of neurotypical young people, and that high levels of social anxiety and difficulties in forming social groups and social bonds with others really limited peer interaction. And then that gives you this whole cascade of impacts because of that limited peer and social interaction. So they don't have as much opportunity to talk about, joke about, learn about sex and sexuality from their peers. They may take things literally that are not meant literally. They may misinterpret social cues. And misinterpretation of social cues can make you much more vulnerable. When you can't read someone's intention, you may misinterpret their attention, and so it makes you more vulnerable to abuse. And then this is another very recent study on, and again, the language here is language straight out of the study, so I am not taking responsibility for the language. This is how they defined their population as adults with Asperger's syndrome and high-functioning autism. So their data was that 73% indicated that they'd had some romantic relationship experience, more women than men. 7% had no desire for any romantic relationship experience, which does not mean they're asexual. It means they're not interested in a romantic relationship, okay? That individuals with autism spectrum disorder whose partner also was on the autism spectrum were significantly more satisfied with their relationships than those who had neurotypical partners, and that the severity of autism and range of symptoms and empathy skills, the need for social support, all were not correlated with relationship status. So the assumptions we might make about whether people get into relationships or not, informed by how we see their level of function, is not really predicting their interest or engagement in romantic relationships. So this is from a meta-analysis, sort of a summary of the findings, because there's been this kind of big surge in research around sexuality and people with autism. People with ASD, especially women, showed a higher diversity in sexual orientation as compared to the neurotypical population. Women with ASD were more frequently in a relationship and reported more previous sexual experiences than young men or men in general. Sexual education programs specifically addressing the needs of people with autism are scarce. And I have not been able to find anything in the US. Again, there is a program that's been developed and has been trialed in Scotland with very good results. There are people here at UC interested in bringing it here to work with in their autism program at Langley Porter, so we'll see what happens with that. But it is developed to be a school-based program. And individuals with ASD show the whole range of behaviors, normal to problematic sexual behavior, just like neurotypical people. There's nothing particularly unique in that way. So as a provider, you have to accept that you may have to go outside your comfort zone. Now, I provide services to adolescents and young adults. I have for 35 years. I talk about sex with my clients all the time. Many pediatricians do, many pediatricians don't, many adult care providers don't. So you have to be willing to go there. You need to be able to talk about self-pleasuring or masturbation as healthy and normal. It's a normal outlet for sexual desire and for sexual energy. Many experts believe that inappropriate sexual behaviors are the result of not having any outlet, any appropriate outlets. So this is why I really say you have to be willing to go there and talk about it and legitimize it. And you know, in my client population, half the kids think that masturbation gives you acne, the other half thinks that it cures your acne. But you know, they're thinking about it, they're doing it. We're just not talking with them about it. And be aware that people with disabilities need both permission and sometimes instruction. And so it's really important to partner with their family or support system, find where's the appropriate place for instruction and appropriate instruction. Sometimes it's just problem solving, like what do you do when you have a lot of lower limb spasticity and any stimulation on your thigh is going to cause you to just clamp up and tighten up, and you know, how can you have sex? How can you think about positioning? What's going to be comfortable for you? So problem solving. But to engage in problem solving, you have to engage in a pretty intimate conversation. I would say probably a very intimate conversation. And you have to anticipate some of the problems that might come up by thinking about what is this person's disability, how does it affect their function, what is their level of physical function, how might sexual stimulation or sexual encounters with others impact on their disability and their function. So in talking about self-pleasuring, first concept is public-private. You know, where is this appropriate behavior, where is this not appropriate behavior? Normalizing, everybody does it, this is normal, this is healthy, and giving permission. Again, helping people figure out about positioning and helping them to anticipate positioning. I had a client talk to me about using a vibrator, and that she found, is a client with CP who had spasticity, intermittent spasticity, and she said it just made her really tight. And so for her, it was not a comfortable experience. And it's something that someone had recommended to her, a peer, said, you know, try it, you might like it, because she had some issues that, you know, couldn't really do manual stimulation because of her disability. But for her, a vibrator, or at least on the speed she had it set, just caused her to really be tight. So these are not conversations we're used to having with our clients, but these are conversations our clients need us to be willing to have. People with intellectual disabilities may need help figuring out appropriate context. So again, that issue of context and individualizing context, and everyone needs privacy. And I'm here to acknowledge that as a parent, I am so used to bursting into my 20-year-old's room. It has taken me so much work which with my typically developing older child, I never would have dreamed of bursting into his room probably after the age of 12 or 13 without knocking. And I'm an adolescent health provider. But here I'll go walking into my daughter's room at any time of the day or night without knocking first. So we as parents forget, we as providers forget, but our clients, our children, our family members need us to remember that they are full human beings, they are adults, and they need their privacy. Remember that some of your clients are going to remain concrete. So they're present-oriented, their experience, their friends' experience is what counts for them. They have a pretty limited ability to project into the future, and they're not generally realistic in their projections. And they really can't make that connection between the long-range outcomes of their current behaviors. So risk reduction is very challenging to both teach to a person who's a concrete thinker and to motivate them to engage in, because they're in the moment. Whereas abstract thinkers, this is what we can use typical health education interventions. They can envision alternatives, they can evaluate them, they can take other people's perspectives, they can reason about chance and probability. This is all health education risk reduction is based on these concepts. And yet we have many clients who don't have the capacity to really understand these concepts. So what does this have to do with sexuality? Well, negotiating relationships is a learned skill, and people with disabilities have fewer opportunities to practice it through friendships, fewer social outlets, higher levels of adult supervision. They desire romantic relationships, but they often don't have models among their peers, and sexual decision-making requires abstract thinking. Parents and caregivers and providers have many concerns. Our concerns are legitimate. Concern of abuse and victimization is a legitimate concern. Concerns about partner choice, concerns about dating. For parents, that concern about really being able to let go, and will their adult child be safe? And concerns about their adult child's desires to parent. And I have to say that healthcare providers also kind of buy into this idea that people with disabilities can't or should not parent. So we can't talk about sexuality, unfortunately, without talking about abuse because it is a very real issue for people with disabilities. There's greater vulnerability with greater dependency on others and with communication limitations or difficulties. With mild impairments, victimization can sometimes be due to that desire to fit in. I want to be like everybody else. I may misread the situation, but everybody's doing it. I want to do it too. Abuse does occur more frequently with family and caregivers. Only 14% of reported abuse is what we would call stranger abuse. The rest of abuse is family and caregiver abuse among people with disabilities. And the American Academy of Pediatrics data is that there's look at this range, 2 to 10 times. This is because of reporting biases. We really don't know, and it varies in different populations, but significantly to extremely significantly more prevalent than the general population without disabilities in terms of abuse. And 68 to 83% of women with developmental disabilities will be sexually assaulted at some time in their life. So we can't talk about this without talking about abuse and the concerns related to abuse. So why are people with disabilities more vulnerable? So what influences these statistics? People with disabilities are less able to defend themselves. They're often not alert to what is a dangerous situation. They don't have that gut feeling, or they haven't been taught to trust that gut feeling. And again, this misinterpretation of signals and messages from others. They don't know to report abuse, and when they report abuse, they are not listened to, they are not believed, they are not acknowledged, and they are not taken care of. People with mild intellectual disabilities may be more vulnerable, again, because of this desire to fit in with their peers. People with disabilities are exposed to a huge number of caregivers who engage in intimate care, whether that's, their paraprofessional in elementary school who might be wiping their bottom, to as adults, people are helping them with dressing, with positioning, with toileting, with transportation, etc. So the opportunities for inappropriate touch and for abuse are myriad. And people with disabilities are taught from a very early age to be compliant, to follow directions, to do what they're told, to let the person who's doing what they don't want done do it, right? I mean, my daughter's been in physical and occupational therapy since 10 months old. She's had people pulling on her legs and trying to get her to spread her legs, and all these things that she has the intellectual capacity to know the difference. And in fact, at age 7, it wasn't the best way to handle it, but she had a new provider. She was in one of these clinics where there was 10 providers walk in the room, and somebody walked up, a male provider, and started to pull down her pants, and she slapped him. And I said, so don't slap the doctor, but I'm proud of you. You did good. That's right. And she said, he didn't ask. And I was like, right, he didn't ask. So we can counteract that compliance, but we have to be aware that there is that compliance. So I took a few quotes. I tried really hard to put in the audio from how many of you listened to the NPR series on abuse and disability? If you have not listened to it, there's a podcast. You can Google it. You can search it on the NPR website. And it is really, I found it really excellent. And the best thing about it was that there were so many voices of people with disabilities. And so my very limited technical skills prevent me from sharing the literal voices, but I want to share the stories. So this is from a series that was called In Their Own Words, and this was a gentleman, older adult, Thomas Magram, who lives in Washington, D.C., and he said, "We are taught to trust grown-ups more than anyone else would be, because when you have a disability, people are always telling you, do as that person says, do as this person says, and all this other stuff." Or as Cindy Whitaker in Austin, Texas said, "It happens to people like us," she's talking about abuse. "And why is because we're easy targets to take advantage of. We think that people that we're around, you can trust them, but you don't know that by looking at them. You just can't judge a person by their looks." Or as Debbie Robinson from Philadelphia said, "I was thinking maybe it was just a relationship, a bad one." She's talking about a sexual assault when she was raped. So I was thinking that maybe it was just a relationship, a bad one. I was just in denial. I had to figure out that it's not my fault. I had to go through all the memories and name it and open up that box you really don't want to open up, Pandora's box. And Debbie Robinson has actually become an advocate working against sexual assault and vulnerability. The other things that were really impactful about this series were stories of the response of the legal system, from law enforcement, but particularly the legal system, where you're not a good witness, your story isn't believable, you don't know the difference. So all of these things really impair reporting and re-traumatize an individual who's already been traumatized, because the process of reporting and trying to get any legal response is traumatic as well. So some warning signs for your children, family members, clients, who, particularly those who have limited verbal abilities or ability to communicate verbally. So these are things just to watch for. And it's not that 1 + 1 = 2, and every time you see these behaviors, it means there's been abuse. And abuse should be in your differential, should be on your radar, you should be thinking about it. When a client, for example, refuses to go with people or to places that previously they were fine going to. So I had a client who was going to a local program, had been going there for a number of years, was very happy there, suddenly started crying and moaning when the bus arrived to take her to the program. And then started biting herself. She had had some self-injurious behaviors when she was a younger child, started engaging in those behaviors again. She was not verbal. It turned out, and she had a great parent who was really willing to investigate and talk about this, and on my encouragement went and tried to figure out what had changed at the program. And what had changed was a staff and a supervisor. So there was new staff and there was less supervision, and it was actually, there was staff who was abusing her in her program. So these things happen. We need to be aware and alert to them. And when you see these kinds of behavior changes, anxiety, frustration, and self-injurious behaviors, an increase in sexualized behaviors like masturbation, just as you would with children, these can be signs of sexual abuse. And you need to be alert to it. And obviously any distress, they could be feeling unwell, they could be having a toothache, they could have a bladder infection. There could be a lot of things going on, but you need to keep abuse in your differential and think about it. So moving away from abuse and back to relationships. Where does capacity fit in? So I just want to remind you that legally, the bar is very low. In the state of California, any individual seeking care for pregnancy-related services, so that's pregnancy prevention, pregnancy management, pregnancy termination, of any age can consent to their own care. And yet we tell a person with an intellectual disability we think they can't consent, right? So the bar is not high. But the individual needs to be able to say no or express no, and they also need to be able to hear no and respond appropriately to no. So, again, there are many risks for abuse, there's also many risks for being labeled a perpetrator when you're a person with disabilities, particularly a man with disabilities who may just, for example, engage in self-sexual stimulation in a public rather than private environment. A mistake that people make, they can learn not to make that mistake, but they get labeled. So you need to be able to say no, you need to be able to hear no, you need to understand those basic things about what happens, what are the adverse outcomes if you have sex with another person in terms of pregnancy and STI risk. You need to be able to differentiate appropriate and inappropriate places. You need to be able to recognize persons or situations that might be a threat. So this is, I know you can't read this, but I wanted you to know that this exists. So how many of you have ever tried to assess capacity in a client? Do you have tools to assess, objective tools to assess capacity? They just aren't. So this is, again, I think this one's from Australia. Oh, it's from Canada. Yeah, this is Canadian. It is not perfect. and it gives you some kind of guidance for informed voluntary consent checklist and sample questions. So some way to really assess capacity, and it even gives you, so you have these questions that you can ask and answer, and then it gives you some guide of capable, not capable, or unsure. So it gives you some place to start at to think about whether this individual really has the capacity to consent. So it's a nice tool. But again, I think we really need to think about whether we're even thinking about this or going there. I don't know, you can probably read this cartoon, the punchline being, you're only 28, you still have plenty of time, okay? So as family members, we often really don't feel like our adult children with disabilities are actually adults. We don't treat them as actual adults. And we always have other priorities besides their sexual lives, right? So discrimination can begin in the family. But support can also begin in the family. So all of those skills that we teach parents, particularly parents of children with intellectual disabilities or cognitive disabilities, around scaffolding, we can use those same skill sets, social stories and scaffolding, to teach about dating, to teach about relationships, provide lots of support, and gradually, in appropriate ways, withdraw support. So the first time, you might, go to the movies and sit with the couple. And the next time, you might go to the movies and sit in the same movie, but not with them. And the third time it might be in the same multiplex, but you're going to a different movie. And eventually you might get to the point that they can go on the bus or paratransit or whatever and go to the movies by themselves. So those scaffolding principles that we use for teaching so many skills are very appropriate for dating skills as well. The internet and social media really can be a fantastic tool to safely explore relationships. It requires the same skills as face-to-face interactions, but you have more time. You can write something, look at it, and go, oh, that sounds kind of weird, and erase it and write it again. I watch this process with my daughter all the time. She'll write it, and then she'll look at it, or she'll ask me to read it, and she'll go, does that sound weird? I'm like, oh, I don't know. She goes, I think it sounds weird. So, that real-life one-to-one, it's hard to reboot over and over. But exploring the virtual world can actually be a great opportunity. It requires support and supervision and involvement of a parent or caregiver or coach or therapist or whoever, and gradual letting go, as with all of these skills. And it's, again, as I mentioned, that transition from the virtual to actual world is where risk is. So then click into those issues around scaffolding, use really concrete ways. I had one mom tell me that she actually, because she had a 30-something-year-old, I can't remember, with an intellectual disability, who was very interested in relationships and was meeting all these people on the internet and wanting to meet them in real life. And this mom, finally, her mom kept telling her, it could be anybody, you don't know who they are, you don't know they're saying they are that. And so finally her mom signed on with a fake ID, identification, a fake picture, engaged in a conversation with her daughter, and then came and said, you were talking to me. Okay? So you can't get more concrete than that. I thought it was a pretty creative way of trying to impress upon her daughter that she said, I was very careful to not let it go too far. So it was just the getting to know you phase. But she said, you thought you were getting to know this guy your age, and you were actually getting to know me pretending to be a guy your age. So if I can do that, anybody can do that. So I want to close by talking about pleasure, because I think this is really the missing ingredient. And when we have these kinds of talks, pleasure kind of gets refined out of them. And this is a quote from The Missing Discourse of Pleasure from the year 2000. And this is Michael Tepper, who says, access to pleasure is the real accessibility issue. Full inclusion means access to pleasure. It means a reasonable chance for relationships. And I don't know how many of you are familiar with Sins Invalid, but this is a group that they have a film, they have performances, they do education, and they really focus on people with disabilities and relationships and sexuality. And they're pretty out there, pretty blunt, pretty in your face, and they do beautiful work. So this is just a screenshot from their website. And I'll close with our more typical images of happy couples. So thank you for your time and attention.